The closing session of this summit is very exciting because one of the most gratifying roles of being the center director, and it's why most of us really honestly go into academics, is because we love students and we love early career researchers and really mentoring people through to become strong in their area and contribute to this broader vision that we all have. And a key challenge to digital transformation of the Australian healthcare system is that the clinical research and operational workforces that are required to create this innovation and to be able to translate research or industry-led advances in digital health into routine use in the healthcare system, that workforce is far from critical mass. So recognizing that building that critical mass and that capacity is one of the main goals of the center, we've had a multi-pronged approach to doing that. And one of them is like formal education to teach people. And a program that we're really proud of and excited about is the Learning Health System Academy, and we have people here who have been involved in that. And we have clinicians who are selected by their healthcare organizations to become digital champions, and they spend a year with us 2 days a week working on project-based research and learning. So that's been very exciting. Another way that we've been building capacity is in hiring and recruiting. And we've become, I would say we are becoming a magnet for amazing talent. And so in this session, we will have our early and mid-career researchers get up and just do lightning talks about what they bring to the table. And you're going to see a broad variety of expertise because, as we all know, this digital transformation it's not one field's responsibility. It requires expertise in so many different areas. And we don't have all the capacity we need yet, but you'll see a lot of different expertise in this group of people. You'll see passion and accomplishments and vision for where we can go in the future. So to start, I'm going to introduce the first speaker, who is Sat Dushyanthan. And Sat is she has a PhD, and she is a science communicator. And I call her that. I mean, she calls herself that too, but I think it's really, like, her formal role in the center is she's the Digital Health Workforce Development Specialist. And so she develops educational materials to help people learn about digital health and learning health systems and informatics. But she does that from the perspective of a science communicator who has a passion for helping people understand complex topics in an engaging way. And so she brings artistic talent, creativity, and an understanding of the problem to the table to help our materials be more engaging. And she's one of our she's a superstar of STEM, which is a really exciting achievement that she has, and she's a superstar in our center, so Sat.
Hello. Okay. Hi, everyone. I feel like Wendy's just given my talk, so I don't think I actually need to be here. But yeah, thank you very much for the opportunity to speak today. As Wendy mentioned, I'm Sat, and I'm an education specialist at the center. And today I just want to really talk to you about, I guess, a bit of my journey and what I currently do. So I thought, what better way than to talk about all things digital than to get AI to generate my illustrations for today. So this is just a courtesy to DALL-E AI for making the illustrations that you'll see. So this is me. I started off as a cancer researcher. And, I was really passionate about contributing to, the greater good, doing something a bit different, contributing to new knowledge. But I came to a crossroads at the end of my PhD, and I didn't really know which way to go. Along the way, I'd been teaching a lot of the time. I'd been working on little education projects under the wing of the nursing team, so iBook projects. And so I was really like, let's make a difference. And I was really supercharged by this idea of having Avatar come out in 3D in an immersive experience in my first year of education in undergrad, and then going to class in the lecture theatre and having a textbook picture presented to me and being like, how are these two things happening in parallel? And wanting to do something about it, pretty much. So this is a bit about my journey from translating from researcher to educator to science communicator as well. So it kind of propelled me onto this journey of trying to figure out what education means to me and what are immersive learning experiences. And so I had this really unique opportunity at the end of my PhD to develop a Master of Cancer Sciences in collaboration with the VCCC and the University of Melbourne. And so over 3.5 years, I had this agenda of trying to transform learning experiences. And one of those was through animation, but also, I guess, gamification and VR as well. And this is me transforming into a science communicator. And so yes, I am playing with Lego here. I also dressed up in a onesie and presented in a national science communication program called FameLab and was a national finalist. And during the pandemic, I really found myself having a compulsion to, I guess, fix this agenda of misinformation. And so I started a YouTube channel where I talk about different science concepts. And it's just opened up a lot of different opportunities for me to speak about science in public as well. But what is the problem that we're trying to face in education? Well, we know, especially in digital health, that, and we've spoken about a lot today, there are not clear pathways for people who want to work in digital health or are currently working in digital health. There's no do this degree and this is your job waiting for you at the end of it. So we really need to provide those experiences, and that involves upskilling people who are already kind of working in jobs that are related to digital health, but also providing upskilling of education so people who are in those roles can do their job to the best of their ability. We also know that it takes the skills of many diverse individuals, so lots of different people coming together, having a shared language, shared understanding of what's involved. And so we've really tried to create multi-professional, interprofessional programs. And so I feel like education has a really big role in upskilling that workforce and being able to undertake these digital transformation efforts. So how have we done that? Well, one particular example that I'll be talking about, and you'll hear about a lot of other ones, is this idea of the Applied Learning Health System short course. This is a program in which there are interprofessionals working together, so people from healthcare, people from IT, people from health services management, who all provide these really diverse perspectives and different interpretations of what the problem is, but who come together and they get to learn from each other. The other thing that we're doing is this idea of clinicians and consumers working together. So we all have a unique perspective. How can we learn together, and how can we educate consumers, educate clinicians to the best of their ability, so when they go on to do other things, like contribute on panels, contribute in grants, in committees, that they're informed consumers, and go on to teach and be the teachers of the education that they are involved in. And the third is by providing immersive learning experiences that are really applied, so they can take what they learn in the classroom back to and apply it to practice. And so different ways that we've done that is by using case studies. So we use a diabetes case scenario, which takes them from start to finish of creating a digital health innovation. So we teach them all about how you figure out what the pain points are, who are the people involved in the system, what are the different things they're dealing with, what does that data look like, is it clean, is it dirty, what problems can we solve, how can we get these diabetes patients from not ending up in hospital, what are the different things we can do. And so they go on to look at a different digital intervention, which is a remote care pathway, and they get to have hands-on learning of working through these digital technologies from the perspective of what is that user experience, what does the back end look like, and figuring out how that pipeline works. And so I really just wanted to end by saying that this is a particular anecdote which I thought was really nice. I got an email from a participant who was from India, and he sent this to me at the end of the course, and he said, I really love the course. I've put all of these different diagrams from the course in my clinic, and I have it there as a reminder every day of what we need to achieve, but also as a way of when government officials come in as a talking point for telling them about what I've learned and what I've brought back to my own country. So just to end, I'd like to say that education is really an enabler that helps adoption, and so the pathway to change really starts with education. Thanks. And I'd like to welcome Kaylee to the stage.
Fantastic. I work with Sat in our Education Workforce Development pillar. Her presentation is very 2023. I'm going to take us back to 2015 and smart art. So my background, it looks very linear. but was actually, like a lot of you, a very windy road. So I started in the States wanting to be a director of pharmacy in a hospital and did different administration programs and got my pharmacy degree. Wasn't yet interested in digital health, although my hospital did go through 3 electronic medical records in 4 years, going from Siemens to Cerner to Epic. So I think about that a lot right now. From there, though, being in administration, I got really interested in education and wanting to work back when students come to us back in the schools. So I went and got my PhD in educational psychology, getting really interested in psychology, and then found myself in Australia in a fellowship, thinking it was just going to be 2 years, fell in love with the country and the culture here, and so I was very lucky to be in my role here in our center for 2 years, working on something I'm really passionate about, which is digital health workforce development. So as far as the expertise I bring to the center, it's really about designing, creating, developing, and implementing education programs. The problems that I really care about and have been touched on today is that digital health is a very complex problem, and complex problems require a team. However, in education, we're often trained in silos, and we don't learn each other's language. We don't learn about each other until we're actually out in the problem areas, the hospitals, the clinics, the health organizations. So really interested in interdisciplinary and interprofessional education, which we've been working on a lot of the last 2 years. Also, really want to make relevant programs. I feel strongly that you can't just take something off the shelf and implement it in a context. I care a lot about understanding the environment, making sure that it's relevant and that we're meeting people to where they are. So really engaging with our potential learners and their employers and the people that they serve when we're creating our education programs. The challenges that we often face in the center is we have this lack of workforce around digital health, and with that, sometimes we have a lack of instructors. And so have been really lucky to be able to collaborate and figure out how to work within that context. And one of the ways that we do that in the center is that we pair our subject matter experts who are overstretched and need to do amazing things and are doing things on site, and we pair them with us in the education team to make sure that we're using their time to the best and we're helping them scale up and making sure that we can get their messages across. And then lastly, I have discovered over the last 2 years just how much work it takes to really have an effective program, which includes resources for marketing and instructional design and evaluation and implementation and scale up, and have learned a lot over that since I've been here. So a lot of that involves being really creative in how we work together with other partners. A case study of this was that I'm lucky enough to be leading from the University of Melbourne's side our National Fire Training Program, where we're partnering with CSIRO, who are subject matter experts, HL7 Australia, that is helping us engage their members, and the Australian Digital Health Agency, which has been funding and partnering with us in this project. Fire is very much just one of those foundational infrastructures that we really need in Australia, need implemented widely. And when I started this project, it was really just about training developers and how to do it. But we had them take a step back. We did a needs analysis, really talked to, I think, 50 different people across the spectrum about what it would take to implement this. And from that, we came up with a plan to target kind of all aspects of this problem, which included convincing higher level executives, so programs for them, involving the clinicians, because they're involved with those problems every day, and how can we get them to see how to solve their own problems, different project managers, safety, consumers, and then of course training those developers. So very fortunate to be working on this project the next few years. And with that, I will hand it over to Cara.
Thank you so much, Kaylee, and it's an absolute privilege to work with everyone in the centre too. So my name's Dr. Cara Burns. I'm an early career researcher here in the centre, and I'm going to talk to you a bit about my work in building partnerships and trying to bridge the silos in digital health. So my career has been marked by variety and a bit of interdisciplinarity and really a boundary-spanning function. I'm what Ruth Bridgestock would call a key-shaped professional. I have multiple areas of discipline knowledge, and hopefully that, as a key, unlocks the value across the silos of digital health. Some highlights in my career were being the only medical photographer in the Northern Territory, were having my honours research published in the Medical Journal of Australia and having the AMA have to respond to it with a top-down policy, doing my PhD in a business school, but running a clinical trial in a paediatric setting using patient-generated health data to look at surgical site infections, and working for eHealth Queensland, where I ran large innovation events and hackathons that drew ideas out of the health system, and a few of them ended up being implemented into the state-based eHealth program. So with that creativity, with my events, and with my innovation hat, I really try to work across the centre and across partnerships. And part of the things that has made it successful for me, and I'd really love to hear if it's worked for you guys, is that we take an approach where we really think about bimodal innovation. So we all have business as usual work we have to do as researchers, but in the centre we have a protected area called the Collective Impact Incubator, which can really work on innovation. In that, we run agile experiments, which could be a project, could be a program, could be a process, or it could be a policy of some kind. And we do expect some of them to fail. But if we're trying to build relationships, even if these initiatives fail, usually we are able to create a sustained relationship. One of the things that we think is really important is to reconcile the time that industry works at and the time that academics want to work at. And so we are working on new methods like the Insights report, which we'll share at MedInfo, that helps bridge that silo between academia and industry. And really, it's very important. We want to work with everybody in our project teams, but we also want to harness the power of the crowd and people generally to do the work that we're doing. So there's lots of ways. If you want to work with us, if you're keen, there's lots of ways you can work with us. We have this sort of funnel around engagement where if you're interested in promoting awareness about a project or a concept like virtual care, we can obviously work with you as academics and we can publish a paper. But we could also run events, and we did that with Bendigo Health. So we ran a virtual care symposium, which was a full day. We had 12 presentations, and we also created a bespoke human-centred design workshop that was very well attended and highly regarded. From that, we actually met Sisu Health Group, and so that created a great start of a relationship, and we decided we wanted to explore a project with them, and so we actually arranged for some interns to come and work with the data that came out of their Class 2 medical device. And after that experience, we decided then that we really wanted to partner with them on long-term, transformational, impactful partnerships, and so we're applying together on the $5 million Pilbara grant together. So this is some of the ways that we work across academia, healthcare services, and industry and government, and we would really love to work with everybody here. So help us bridge the silos of digital health, and if we do, the future of digital health will be bright. So I'd like to invite Olivia Metcalf up for the next presentation. Thank you.
Hi everyone, thanks for having me. So my name is Olivia and I want to talk to you today about digital intervention innovation, the perils and the promise. And a lot of what I'm going to say, I'm so delighted to hear lots of the speakers today already talking about, particularly Professor Khan and Professor Sullivan. So my background is in behavioural science. My earliest memories as a child, can you hear me okay, actually? Yeah. My earliest memories as a child were watching adults interact and wondering why they lied to each other, why were they flirting, why were they drinking alcohol. I should make a joke there, but I'm not. So I really wanted to know, and I was like, and that's just my parents. No. So I was really interested in why humans do that, and I loved science, and then I found out there was this thing called psychology and behavioural science. And I did my PhD at ANU, and then I came here and did my postdoc in the Department of Psychiatry at MDHS. And I've just moved to the centre. And that's because I learned a lot of my lessons in digital health for individuals with mental illness the hard way. They're hard-learned lessons in digital health. And I could see that the centre was trying to get on the front foot about that. So some of the things I'm interested in that we've talked about today is how patients' responses to generating their own health data can be a negative experience. It can also have very unintended consequences on your clinical outcome of interest. I'm interested in how clinicians' pre-existing views around digital tools and all of the workflow issues that we've talked about today can affect engagement with any digital innovation. I'm interested in how a digital solution that replaces a previous human interaction can negatively impact or have no positive impact on clinical outcomes, even if the tool itself is very optimized. And I'm also interested in things like patient digital literacy, health literacy, the tolerability and acceptability of a given solution, how that interacts with the maturity of an organization from a digital perspective. Because of course, digital innovation should not be locking the most vulnerable individuals out of advanced healthcare. So what is the problem? We already know this, but what I'm interested in is that there's no shortage of innovation, and everyone knows about the potential of digital health. There's nothing but innovation in this field. Yet we know that most digital innovations, of course none of ours, but others are considered a failure at the implementation stage. And why is that? So yeah, the challenge and the problem is not the generation of novel ideas and technology to solve complex health problems, it lies in people and behavior, and that's where I hope that I come into it. So I'm interested in things like how the efficiency of the solution is relative to the original workflow. So again, all that workflow stuff we've been talking about. Can we have this solution accessed by all of our patients? That's really important to me. Does the solution itself actually effectively deal with the core issue, and what are the unintended consequences? And I'm really interested in the interoperability of the solution with the broader healthcare system. Unfortunately, Kit can't be here today to talk about the Validitron, but a lot of what I'm doing is within that too. So here's just a little case study of what I've been working on, and I think Kate is here from Deakin, so this is a Deakin-led project, an MRFF grant. I know Greg's left, but thanks Greg again for that one. And this one is using all of those principles to support 12 health services approximately in the Western Victoria region. And they've requested help with their remote patient monitoring tools. Again, we've talked a bit about that. Lots of innovation and a lot of amazing technology in that space, but there are a lot of challenges, and some of those include the region having an older population, high levels of chronic disease, remote and rurally located individuals, and varying SES levels. So some of the work that we're doing, and again, this really speaks to Professor Sullivan's point, is letting the health services lead what it is that they need. So our job as the digital health team is to respond to what it is that those healthcares need, working with them around their current program maturity levels from idea through to implementation. Assessing and really understanding what the health services goals for the remote patient monitoring are and where their challenges lie. And then of course working really closely with consumers, who are the ones who are not able to access, who are locked out of these programs at the moment, and how can we support them. And then of course across the field working really closely with a single site to resolve some of those key challenges around implementation, and then synthesizing those recommendations for the whole region. So just using and trying to deal with some of those challenges when we already have great innovation and technology, but it's at the kind of implementation stage. I think that's all from me, so I'll just introduce now Winona.
Hello, I'm Winona, and I think from all of the talks that you've heard before, there's incredible people, and hopefully I can be incredible too. So my career has been mostly in industry. Full disclosure, I came from pharma, but I'm here with you all now, so please accept me. I've worked with a lot of real-world data, with real-world data problems. And when I say work with real-world data, I mean sitting in front of a computer with no documentation and trying to figure out how to turn this data into something that we can analyze, analyzing it, and then trying to explain what we've got. I've also done a lot of work on the other side in software development. So taking an idea, writing specifications, and coming up with software. So one of the things that I've constantly run into, and this is just informatics, I know, is that sharing data is hard. It's hard work. It's hard because of their institution impediments. It's hard because there are technological impediments. It's hard because there's methodological impediments. And so I'm interested in finding ways that we can facilitate that sharing. And hopefully there will be a day in the future where we can all share data. No, I'm just kidding. But more importantly, like how can we just not only share the data, but close the loop? So we all have the data. We want to be able to get knowledge out of that data, and we want to take that knowledge and put it back into the system to give it back to the people who gave us the data in the first place. So one of the projects that I'm actually working on here in the center is in creating synthetic data and then also creating a Smart on Fire app to kind of use that data. And the purpose of this is to say, okay, you won't share your data with us, so we'll make some data. So we're creating some synthetic data. And then to say, hey, let's show you what we can do if we use, say, a standard like FHIR to create an application that can do something really cool and then feed data back into an EMR. So, just a way to demonstrate, like I said, creating data, using data, and most importantly, closing the loop so we can demonstrate that whole process. And rather than it just being an abstract idea, but a concrete physical thing that people can see and work with and play with. So that's me. Let's introduce me.
Hi, everyone. Thank you for having me. I'll keep it short and snappy. So my name is Mahima. I'm a research fellow here at the center. And the problem I want to talk about is the evaluation of complex, multifaceted self-management solutions. So I'm an interdisciplinary professional. I worked in management consulting for about 10 years before making the jump to academia a couple of years ago. Here at the center, I mostly do qualitative research, both traditional methods like phenomenology, but also non-traditional methods like visual aids and creative visual methods as well. A lot of my role here is focused on co-designing with end users. So I work with patients, caregivers, health professionals to make sure we understand what's actually important to them and translate that into the work that we do. So the problem I want to talk about is evaluation of self-management solutions. And often these solutions are not fixed interventions like pharmacological interventions. So there's often like a personalization element. People will use it on demand. There's often this sort of context of real world usage data as well that changes over time. So because of that, traditional RCT designs are not always relevant because number one, software development companies will develop these solutions in an agile way. So often the timelines don't align with clinical trial methods and so on. So in order to tackle that problem, we think that it's important to create an understanding of the mechanisms of change and the assumptions that lie underneath these solutions. So I just want to present this quick case study. This platform is called BT Online. This is a platform through which we hope to support people affected by brain cancer. So it has 3 pillars: Learn, which is a repository of basically vetted information. So people can understand a range of things ranging from how do I manage my seizures to can I still drive. The second piece is Connect, where we've tried to create peer support connections between patients and their caregivers. And then the last piece is around Toolbox, which is self-management, symptom management solutions. So in order to really examine the assumptions that lie underneath this intervention, we created a theory of change. And I want to draw your attention to 2 main things. So the first one is that it was really crucial that we capture multidisciplinary perspectives. So in order to do that, we liaised with professionals, caregivers, researchers, and so on. And also we adapted a classical theory of change model and applied that sort of short, medium, and long-term outcome lens into usability, efficacy, and effectiveness. Thank you. I'll pass it on to Hassan.
Hello everyone, I am Hassan Ferdows. Today I'll be talking about one of my main projects here at this center. But before then, let me introduce myself. So I'm a human-computer interaction researcher. So what does it mean? So it means that I'm deeply interested in understanding the human factors that influence the use of technology. So how we interact with technologies, both as an individual and as a social group. But also how these computing devices influences our interactions with the device and also amongst ourselves. So I'm interested in both this bidirectional communication. So I specialize in user research. So at this center, I'm involved in a number of projects that focuses on UI and user experience analysis. Say, for example, I work in the telehealth project. I also work on the young stroke survivors, where we are building an integrated platform for the young stroke survivors throughout their journey. I'm also working on a number of other projects involving, say, patient-generated health data that my colleagues have spoken about. So like a lot of my colleagues, so my journey to digital health is not straightforward. I took a lot of detours. So I previously have worked a lot on different novel interactive technologies, especially in the public space engagement. So using, say, augmented or virtual reality applications in public space, in classroom settings. I also worked on a number of different projects that uses natural user interfaces in different social settings, such as family. Here in this center, my work focuses a lot on the what we call the Sim Lab. So I hope many of you has visited this space. If not, I'd really welcome you to our space. So just connect with one of our team members and we'll organize a tour. So this is a physical space where we test a lot of prototypes, both built in-house and with our industry and academic partners. So as highlighted in the photo, so we have a number of different space that we aim to reconfigure as per the needs, but the main spaces are hospital settings, a home setting, and a GP room. And also each space can be observed and recorded by the use of 2 control rooms. So we conduct with our industry and academic partners a lot of user studies in there. So my focus here in one of the main focus that I'm trying to work on is the Sim Lab itself. So we know that role play and simulation have been used as a learning technique in a variety of ways. But here we are bringing it to the digital health technologies. So what we call immersive theater, in building that space, we want to bring people, the users, the GPs, the hospital staffs, and immerse them in an environment, both perceptually and psychologically, and see how we can simulate various scenarios in digital health technologies in assessing those. So it provides a safe, accessible space that can be reconfigured as per the need for the project under consideration. So one of my focus here is to conduct what we call a meta research on the existing research projects that we are doing to see how this space is playing its role, or is it playing its role. So we are conducting a case study on the industry and academic users of the Sim Lab itself. So to see how we can support various configurations in that space and convert into a place that supports the existing norms and practices of the project under consideration. And in doing so, we are asking how real is real enough. So realistically, we will not be able to mimic a hospital space, but we're asking how real is real enough to simulate that interaction that happens in the real world. So thank you, and I'd very much like to welcome you to our space. Just reach out to us. Thank you.